EUS-guided liver biopsy has been well described over the past decade, with studies exploring its safety, adequacy of tissue sampling, and ease of use. With improved needle types and techniques, EUS-guided liver biopsy is emerging as an alternative form of tissue acquisition to percutaneous or IR-guided liver biopsy. EUS liver biopsy has been found to be extremely safe, with the most common complication is bleeding. Unfortunately, there are limited endoscopic interventions available to prevent bleeding during liver biopsy. Our group previously published a technique to prevent liver biopsy bleeding that delivers a blood patch through the F&B needle into the biopsy tract before needle extraction. Here we present a case of bleeding during EUS liver biopsy and ways to manage it. The patient is a 61-year-old female with past medical history of T3N1 pancreatic adenocarcinoma, status post-Whipple procedure and FOLFOX chemotherapy, obesity with a BMI of 31, and former heavy alcohol use. She was referred for further endohepatology workup of discordant findings. She had F0, F1 fibrosis on imaging or shear wave elastography, but clinical picture of cirrhosis with portal hypertension. She underwent full endohepatology workup to determine etiology of cirrhosis with a differential of NAFLD, alcohol-induced liver cirrhosis, or oxyplatin-induced fibrosis. After performing EGD, EUS, shear wave elastography, and PPG measurements, we moved on to performing liver biopsy. Our group has recently developed a modification in performing liver biopsies. We use the dynamic suction technique that involves one pass with 3 actuations. After our 3rd actuation, it is customary to put on Doppler to evaluate for blood flow within the needle tract. We keep the needle in place to tamponade the area. Despite keeping the neotract in for 3 minutes, there was still evidence of blood flow in the tract, and so we performed the blood patch technique to prevent further bleeding out of the parenchyma or liver capsule. While the needle is within the biopsy tract, the F&B stylet is inserted into the needle, pushing out about 25 to 50% of the distal needle contents. This blood patch acts as a mechanical barrier to facilitate hemostasis. Following the blood patch, there was still blood flow on Doppler into the neotract and also into the liver capsule. We pulled out the needle and prepared for gel foam injection. The transducer was kept in place to help tamponade the area. We prepared the absorbable gelatin sponge slurry by cutting the sheet into tiny pledgets and placing them into a 10 cc syringe. The other syringe was filled with 5 cc of normal saline and connected first using a 3-way stopcock. Using the Tesari technique, the pledgets were macerated into a thick slurry-like consistency. Here we see on Doppler blood flow in the tract to the liver capsule. The liver was then repunctured with a 19-gauge needle targeting the bleeding tract. We then injected 1 cc of absorbable gelatin sponge slurry. We performed another injection of 1 cc. We subsequently repeat this a few times as we pull back closer towards the liver capsule. Post-procedure, the patient was admitted for monitoring. The patient's hemoglobin remained stable, and CT later that night demonstrates residual blood product and gas seen in the biopsy tract with no significant hematoma or active bleeding. Liver biopsy revealed nodular regenerative hyperplasia consistent with oxaliplatin-induced portal fibrosis. Despite performing the blood patch technique, we still achieved adequate specimen to make a diagnosis, with the pathology reporting 22 complete portal tracts with longest specimen length of 3.5 centimeters and total length of 5.2 centimeters. At our institution, EUS-guided liver biopsy is performed with a 19-gauge FNB needle using a dynamic suction technique with 1 pass and 3 actuations. Before removing the needle from the liver, E-flow color Doppler is used to identify potential bleeding within the liver biopsy tract. If E-flow Doppler is seen in the tract, we first recommend to leave the needle in the tract for 4 minutes. If E-flow persists after 4 minutes, the blood patch technique can be performed. While the needle is within the biopsy tract, the FMB stylet is inserted into the needle, pushing out about 25 to 50% of the distal needle contents. This blood patch acts as a mechanical barrier to facilitate hemostasis. If E-flow still persists in the tract or there is active bleeding out of the tract to liver capsule, absorbable gelatin slurry injection can be performed by removing the needle and using the EUS transducer to tamponade the puncture site. We prepare the slurry by cutting the absorbable gelatin compressed sponge sheets into pledgets and place into a syringe. We connect another syringe with 5 cc of normal saline to a 3-way stopcock. The Tesari technique macerates the pledgets into a thick slurry consistency. The absorbable gelatin slurry is then injected into the tract with a 19-gauge needle. This preparation can be injected into the neotract or surrounding area to cause tamponade and hemostasis. As EUS liver biopsy becomes increasingly utilized, endoscopists should be aware of potential complications and have a stepwise approach to management. Absorbable gelatin is an embolic material that prevents post-biopsy bleeding through the capsular puncture site. The use of absorbable gelatin for routine tract embolization has been well described in percutaneous liver biopsy procedures by interventional radiology. Following acquisition of tissue sample, the absorbable gelatin slurry is injected easily via the coaxial needle system that they use. Although this coaxial needle system is not available for EUS liver biopsy, we demonstrate that the substance can still be injected into or surrounding the tract. Use of absorbable gelatin slurry within EUS-guided liver biopsy may function as a salvage method for intraprocedural liver biopsy bleeding when other steps have failed and warrants further study for use in higher risk patients.